A 32-year-old female posted for cholecystectomy was referred to the cardiologist on incidental detection of a murmur. She had no past history of heart disease or any symptoms suggestive of diseases of the cardiovascular system. On examination, the important findings were an aortic ejection click and an ejection systolic murmur in the aortic area. The ECG was normal. The chest X-ray was notable for the presence of a dilated ascending aorta, and then the patient underwent echocardiography. The parasternal long axis view shows thickened cusps of the aortic valve with an asymmetric closure line suggestive of bicuspid aortic valve. On parasternal short axis view, the right and left cusps of the aortic valve appear to be fused with anterior posterior opening of the leaflets, and possibly there is a raphe also seen in the fused cusps, which is suggestive of type 1 in the conventional classification of bicuspid aortic valve. And then on apical 4-chamber view, a CW spectrum shows that there is no aortic stenosis or regurgitation. Bicuspid aortic valve is the most common congenital cardiac abnormality affecting about 2% of the general population and hence quite commonly encountered in our clinical practice. Frequently, an asymptomatic patient is diagnosed incidentally on the detection of an ejection systolic murmur. The ejection systolic murmur can have various mechanisms of genesis in different cardiovascular diseases, and in a structurally abnormal valve like the bicuspid valve, even in the absence of significant stenosis, an ejection systolic murmur may be generated, the accompanying ejection click pointing to the valvular origin of the murmur as opposed to the supravalvular or subvalvular origin. An aortopathy is seen in 20 to 40% cases of bicuspid aortic valve and is an intrinsic abnormality of the aortic media independent of the severity of aortic stenosis, just as in this patient. Most commonly involving the ascending aorta, it can lead to formation of an aortic aneurysm and is a risk factor for aortic dissection. On echocardiography, the right parasternal view may be employed to better visualize the ascending aorta, and the suprasternal view must also be obtained to look for coarctation of aorta, which is seen in about 10% of patients of bicuspid aortic valve. Regular follow-up, including echocardiography, is warranted for evaluation of progression of aortic valve disease and for monitoring the expansion of the aorta. In the present case, the patient underwent a cholecystectomy with an uneventful intraoperative and postoperative course. She was discharged with the advice to undergo regular follow-up with the cardiologist.